Am I up? Okay. The next person I want to introduce is a breast surgeon, Dr. Gilmore. He did his residency training at Johns Hopkins, came here to West for his breast surgery fellowship, and we couldn't let him go. So we hired him here at West, and he is really been a champion for patients, and I look forward to working with him. Come on. Yes. And then Miss Ott. He's a physician assistant who's been working with West for a while. She worked with Dr. Schwartzberg from actually almost from the start of her, from the start at West until he moved on to different pastures. She continues to work in clinic. She does, her clinic is mainly a long-term follow-up clinic. We appreciate you today. Come on up. All right. Oh. All right, thank you. All right, so let's talk about this case. We have a 39-year-old female, so it's a triple negative case, African American. She presented with a palpable breast mass. Her last mammogram was 1 year ago. Showed heterogeneous heterogeneously dense breast, sorry. This was palpated 3 weeks ago on physical exam. It measured about 4.2 centimeters, had a mammogram ultrasound, confirmed about 4.7 centimeters. Ultrasound of a single lymph node was concerning. She had a biopsy showing triple negative breast cancer, invasive ductal. She also had a history of, family history of breast cancer. Genetic showed a BRCA1 mutation, and she had staging CT scan, which was negative. So first question, Lee, for this patient, what regimen would you recommend for this patient?
Well, based on the data that we just talked about, she's triple negative, she's T2 at least, N1 probably, and so I would recommend, she's young, I think she would go for the Keynote trial, and she would get carbotaxol followed by AC neoadjuvantly with pembrolizumab to start.
What factors would you consider when deciding on other treatment options for, especially in the adjuvant setting?
So one question about, or maybe you can just put the next bullet up, because, oh, that's surgery, okay, yeah. Sorry. So one question I didn't talk about was whether the benefit was in the node-negative patients in Keynote and 522, and it was. It also, so the stage 3 patients benefited, so did the stage 2 patients. So even if they're node negative T2 and they're fit for chemotherapy, I would treat them in the neoadjuvant setting. Much more complicated in the adjuvant setting. So the question is, first of all, if you get a PCR, do you really need the next 8 months of pembrolizumab? And by the way, I didn't talk about the toxicity. It's about a 20% incidence of thyroid dysfunction, which presumably is lifelong, 15% hypo and 5% hyper, and then some other smattering of autoimmune toxicities, which generally are short-lived. So we don't know the answer to that question. However, it was still a 2% benefit for the adjuvant patients over, for the PCR patients who got adjuvant Pembro, they all got adjuvant Pembro compared to the control arm. So they're a high-risk group, maybe they should still go, and that's the standard. Now, in the non-PCR, it's really a question. I showed you that this data, and your patient had a BCRA mutation. How do we combine the drugs? Should they get Pembro and olaparib? Should they get Pembro followed by olaparib? Should they just get Pembro? We don't have the answer for that question. In my own practice, I would consider, in this patient, if she had a non-PCR, particularly if she was RCB 1 or 2, I'm sorry, 2 or 3, then I would recommend probably finishing the Pembro, then doing olaparib. But you can combine them. We've done other trials with combined PARP and checkpoint inhibitors.
What if she was not BRCA mutated? Would you consider Xeloda?
I'm not super enthusiastic about adding Xeloda, the toxicity there. I think I definitely wouldn't do it in the stage 2 patients, and in a very high risk stage 3, I would consider it.
Yeah. So importantly, there are combination studies, some outside of breast, that showed the combination of Xeloda or a PARP inhibitor with pembro is safe. So just FYI.
Yeah, it's been used in other settings,
yes.
so definitely. Yeah.
All right. So, Dr. Gilmore. So having lymph node involvement before chemotherapy, does that solidify your decision about what you're going to do on the axilla, or you want to wait until you get her surgical path?
Yeah, I think we need to know more information. I think she definitely will need nodal evaluation. She has a biopsy-proven positive lymph node. The question is, what surgery do you want to offer her? And I think it depends on her response to chemotherapy. I think that probably the most notable and well-recognized trial on this was the ACOSOG Z1071 trial, which looked at the false negative rate in doing sentinel lymph node biopsy in patients who were initially node positive and then became node negative. And even though that study actually didn't find that it was acceptable, they set a cutoff of about 10%, they did find that with the use of certain intraoperative techniques that you can get it to an acceptable rate. So those would include using dual tracers, so that would be blue dye in combination with a radio tracer, such as a technetium-99, getting the clipped node, so the positive clipped node in this case, and then getting at least 2 and preferably 3 sentinel nodes. So with 2 sentinel nodes, you take that from down to 10% or so, but with 3, it's a false negative rate of 9. And so we consider anything below 10% to be acceptable. And so really that's the long answer. The short answer is that we should wait and see what the response to chemo is.
Okay. So are there any other tests you would consider for this patient?
Yeah, I mean, with her BRCA1, with her heterogeneously dense breasts and her young age, I would consider an MRI because I think that it would, even though I'd recommend bilateral mastectomy, it would change my management in terms of nodal evaluation on the contralateral side if she were to have a synchronous contralateral breast cancer. So I would get an MRI.
Thank you. All right. Same as above, radiation, lymph node involvement,
Right.
BRCA positive, T2N1. Is your mind set on what type of radiation she's going to get?
It is, but it's interesting why my mind's set on this. So first I want to say how helpful it is to have the nodal biopsy up front from a radiation oncology perspective, because it really helps solidify our decision making that oftentimes will come after a long run of neoadjuvant chemotherapy and surgery. But in this case, really it's her age that actually is dictating the radiation for her. You know, being under 40, her young age really predicts for an aggressiveness of the tumor locally. So any patient that's node positive, we typically recommend radiation when they're under 40 years old. So in this case, she'd have an indication for regional nodal irradiation. Now that was at West Cancer Center, that's typically a 5-week course of therapy. Now, depending on the surgery that she has, she can have a little bit less radiation. So she may not necessarily need a booster radiation, which is a subsequent 1 more week if she has a mastectomy, because recently we've learned that actually the post-mastectomy scar boost really only adds to toxicity in patients that have negative margins and don't have T4 disease, which she clearly doesn't have. The other indication for radiation would be stage 3 disease, which she is close to having, but doesn't have up front.
All right. She's still interested in preserving her fertility. So up front when you had this conversation with her, what are her fertility options, Ms. Ott?
I think the main thing is that you need to get her in now to fertility. She's going to need neoadjuvant chemotherapy, which means that she's going to need to start that as soon as possible, and fertility does not happen overnight in terms of egg retrieval and that sort of thing. So that would be all in their hands from that point as soon as possible, but what we can do on our end is to protect her ovaries with ovarian function suppression so she can maintain her fertility potential after she gets through all of the stuff that we're about to throw at her.
Thank you very much. I do have a question here that I want to throw out. How would you treat, I guess that's more on a Lee type question. How would you treat an elderly female triple negative with AFib, COPD, received neoadjuvant chemotherapy with weekly paclitaxel, only 3 doses of carbo, extensive residual disease at surgery. On Xeloda adjuvant and PET now shows a bone lesion 5 site. Would you biopsy bone to decide treatment? So essentially, this is an elderly patient who was in the curative setting, had chemotherapy, didn't respond, had
Some chemo.
not optimal chemotherapy, but probably because of her age and comorbidity, and now she has lesions in her bones that are concerning.
Yeah, so I mean, this brings up a whole area that we haven't discussed, many whole areas we haven't discussed. How do we treat geriatric patients, and how do we treat patients best who are unfit for standard therapy? And it's a little outside of the scope here, but I would biopsy her, and the patient could be a candidate for single agent chemo, as per what you showed, Greg, 355. So if she had a PDL1 of greater than 10 and was triple negative still, and could get nab-paclitaxel, and seems like she could tolerate taxane, so that would be a possibility. Otherwise, to be honest, you really have to do ad hoc regimens, and you have to change your regimens for this type of patient.
Yeah, and I would add, I would consider bone-directed therapy on her for the bone involvement, and I would send a molecular profile. Maybe she has a somatic BRCA mutation that olaparib now becomes an option for her potentially.
Yeah, and I would even do germline on her,
Yeah.
because you really don't have much options, and olaparib is relatively well tolerated. So if she did turn out to be very unusual, but without a family history, but it's not 0. So you're looking for everything.
Yeah. All right. So case continued. She completed chemotherapy, paclitaxel, had bilateral mastectomies, 1.2 centimeters residual disease, no lymph node involved. Her only complaint was mild numbness in the tips of her fingers. Are you satisfied with her axillary management?
Again, it depends. So I think it goes back to what I was saying before with, how did she respond in her axilla clinically? So did she normalize her ultrasound? Z1071 did include ultrasound evaluation with clinical palpability of the lymph node. So I'd want to know, did she become clinically negative? If so, I think we could proceed with a sentinel node biopsy. I'm not sure what kind of axillary surgery she got in this case, but if it was a sentinel lymph node biopsy, I think an intraoperative frozen evaluation would be sufficient. And if that's negative, then I'm fine with that. And now now, in terms of axillary dissection, our overall guidelines really suggest that we should be getting 10 or more lymph nodes. I think that it's a complicated question.
Sometimes you get what you can get.
Yeah, because I think it's more of just removing completely the nodal tissue in levels 1 and 2, and that's really how we define it. And because some people will have less than 10 lymph nodes in the axilla, some people will have over 40, so it really just depends on the individual patient.
Yeah. So, Dr. Farmer, you kind of answered that already. She cleared her axilla, but had disease in her breast. Does that change your treatment plans at all?
Residual disease in the breast after neoadjuvant typically does not change our decision making, but based on her young age and nodal positivity, she would have an indication for regional nodal irradiation. So we would treat the supraclavicular, axillary, internal mammary nodes plus the chest wall in her case. Now, what would be interesting about her is if she was older and had a mastectomy, and with this response, could you then make an argument maybe she wouldn't even need radiation, which you probably can.
Yeah. All right. Lee, I think we talked about that, we covered that. What do we know about the safety of radiation with some of the chemotherapy approach, concurrent, Xeloda versus pembrolizumab, or even olaparib?
Okay, so Xeloda is the one we know the most about, and that is one that we routinely use in patients that don't have a path CR. And that study, we actually had to contact the authors of the study to find out how they sequenced it, but they actually did it sequentially and not concurrently. If you do Xeloda with concurrent chest wall radiation, you're going to greatly enhance the acute skin toxicities. That may be desirable if you have a lot of residual disease in the chest wall or some reason to do that, but it is unnecessary in a typical case where there's no residual disease in the chest wall.
Yeah. What are you looking for when you see this patient in follow-up completion of adjuvant therapy, Ms. Ott?
So her highest risk of recurrence is in the first couple of years after therapy, so you're going to watch her like a hawk for every couple of months, looking for possible neurological symptoms, respiratory symptoms, abdominal pain, laboratory abnormalities. With this patient, also knowing that she's trying to get pregnant, you can also be looking for post-chemotherapy toxicity that may show up later, like iron deficiency or B12 deficiency, that sort of thing. But we'll all breathe a sigh of relief after she gets past that.
Yeah. So Lee, I'm going to go back to the Xeloda question a little bit because I've had sort of a change in thought of management for who I give Xeloda. So assuming she wasn't BRCA positive and had residual disease. So traditionally, we've sort of been adding Xeloda to the 2 and 3 patients. At least I've been doing it. But I've had, second thought about whether or not the ones should be getting Xeloda. And that's based on the SWOG trial that compared Carbo and Xeloda, where most of those patients were high risk RCB 2 and 3, and there really wasn't a benefit for Xeloda. And then when you went back and you look at the CREATE-X study, a significant percentage of that population were actually RCB1. So maybe that's the population who's benefiting from Xeloda.
Yeah, I don't disagree with you. I think the other thing that's strengthened, I'll tell you, I know anecdotally from our discussions, we haven't felt that Xeloda has had a huge impact on our patients, on the high-risk patients. But there was just another meta-analysis, admittedly weighted by CREATE-X, but still other trials that show about a proportional 15 to 20% benefit from Xeloda. So I think you're right. It may be that the lower-risk patients, of which are less likely to relapse but still have a significant risk, might benefit the most.
Yeah, so I've actually changed my practice, adding it to 1, 2. All right, do we really have 3 minutes? Is that what the time is telling me? Yeah, all right. Run through this and maybe one question. 75-year-old female, hormone receptor positive, presented with primary mass evaluation in the left breast. First noticed that 5 months ago. Saw a PCP, had a diagnostic mammogram, had a speculated hypoechoic mass of 2.1 centimeter in the left breast, biopsy confirmed IDC, invasive ductal, that is ER, PR positive, HER2 negative grade 1 with a Ki-67 of 25. Breast exam, 2.6 centimeters, ECOG performance status of 0, had a life expectancy of greater than 10 years. Lumpectomy showed a 1.9 centimeter invasive ductal carcinoma, 0 out of 2 lymph nodes involved. Do you send a genomic assay on this patient?
Wait, can you go back? How old is she again?
She's 75.
75, so it's grade 2, and the Ki-67 is 25, so yes. So the ones I don't send it on are those that are ERPR strongly positive, grade 1 low Ki-67.
Oh, I see.
And so that's based on TAILORx?
Yeah.
Okay. Do you recommend radiation, and what are your options?
This is a really controversial subject for us right now because
why
of
it's
the
here.
genomic assays. Okay, so the answer is absolutely we could do radiation, but we typically recommend observation for this patient. Her lymph, I'm going to leave the lymph node discussion to you, but basically radiation will reduce the 10-year risk of ipsilateral breast tumor recurrence from 10 to 2% with no change in overall or mastectomy-free survival. Now, the wild card for this patient population is the genomic assays. So if the Oncotype or the MammaPrint have been ordered, how do you use that? Because they weren't even invented when the studies came out that we used to do observation in this patient group.
So what if it's high?
So if Oncotype is high, I usually recommend treatment. But MammaPrint is trickier because more patients are high risk with MammaPrint. So we're working on, but I think we're going to have to choose a number in the high-risk MammaPrint to use as a threshold. It's probably going to be about 0.3, but I mean, we're still sort of working through that.
And so the
I
final
think that's
question,
a research question.
yeah.
Yeah,
And the
it's
final
very much-
question for you though is where do you put in the accelerated whole breast irradiation?
Okay, you mean the fast forward.
Fast forward.
So anyone is eligible for fast forward, which is just
Can you tell what that is? Okay.
yeah, so it's 5 fractions of whole breast radiation, and it is equivalent in outcome to our typical 4 weeks of whole breast radiation that we do, or the older technique, which was 5 weeks or 6 weeks. So in outcome, it's the same. And anybody basically is eligible for this, although there is still some concern about long-term cosmesis. Then in the study that it was originally done, 26 gray over 5 fractions was found to have no difference in cosmesis, but 27 gray in the same study in 5 fractions actually had a worse cosmesis. So there is some question, is 26 and 5 versus 27 and 5 really that different? And why did we find no difference for the 26 gray where we did find a difference in cosmesis for the 27 gray? That's an unanswered question, and the cosmetic outcomes are only at 5 years at that point. So right now what we've done in our practice is we're offering this for older patients, even younger than 70, usually we 65 or older. And the response from the patients is they really like this quite a bit.
Okay, so it's not ready for everybody yet.
I would not recommend it for somebody that's younger based on not knowing exactly what's going to happen at 10 years with the cosmesis, but it looks pretty good right now.
All right, I think we're out of time. I appreciate all of you guys for coming here, and thank you very much. Brad?